Welcome. Yeah, yeah. Good evening to you all and New Year, Happy New Year to you all.
Happy New Year to everyone.
Same to
Pranam sir,
everyone.
Raman sir, Pranam sir.
Sir.
It's 6:30, sir. We'll start.
Yeah, yeah.
A very good evening to one and all. On behalf of API, ICP, MESAT, and Old Medical Academy, I heartily welcome one and all for this virtual program on update on upcoming respiratory viral fevers. I welcome all delegates who have joined virtually from whichever place to learn from the esteemed faculty. I welcome our guest of honor, Dr. P.S. Shankar, Professor Emeritus RGHS Bangalore and KBN University Gulbarga. I also welcome Dr. Maya, Patron, Dr. K. Govind Babu, Chairman API, Dr. Vishwanath, Secretary, Dr. Ravi Kirti, Central API Member, Dr. Rashekar, Immediate Past Chairman API, and Dr. Shivraj Shetty, President MESAT. I welcome our guest of honor, Dr. Muruganathan, Past President API and the past Governor ACP India Chapter and many other organizations. I welcome our today's chief guest, Dr. Girish Mathur, who will be joining shortly, the National President of API from Kota, a great academician, researcher, and the recipient of many awards and fellowships with many publications, both national and international levels, a great name in the field of physicians in the country. I welcome our today's speaker, Dr. Raman Gangakedkar, former head ICMR Delhi, a scientist, former director NARI Pune, who never said no to our any invitation earlier for updating our faculty, a Padma Shri awardee, a great work done in the period of COVID-19 pandemic, advising the Ministry of Health and Government of India, and also educating and updating the faculty all over the country. I also welcome our chief moderator, our own faculty, Dr. Murali Mohan, senior pulmonologist from Bangalore, a great academician, a dynamic pulmonologist, and a master teacher. I also welcome our today's panelist, Dr. Ishwar Gilada, who will be joining shortly, the President Emeritus, AIDS Society of India, and the Secretary General, Organized Medicine Academic Guild, OMAG, Mumbai, whose name is on the national international map, a senior faculty with many publications and recipients of many awards and fellowships. I also welcome our other panelist, Dr. Ravindra Mehta, a dynamic interventional pulmonologist from Apollo Hospitals, Bangalore, renowned internationally, recognized all over the country with high academics. I also welcome our friend Dr. N.K. Singh, senior physician and director of CME India from Dhanbad, Jharkhand. His services are recognized by teaching all the faculty all over India by WhatsApp and other so many social medias as well. Let us not waste the time by reading up their CV profile, which runs in pages. Let us utilize the time by hearing and exchange of knowledge with them in their respective specialty. As many delegates who have registered from many states, making a national event. The advantage of virtual meeting, which COVID-19 pandemic has taught a new normal life. Now we have a formal virtual inauguration.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तु ते शुभं कुरुत्वं कल्याणम्
We are virtually honoring all our guest faculty for their tremendous contribution to their work done in the respective field in the country. Now I request Dr. P.S. Shankar sir to address the gathering.
Friends and colleagues, we have assembled for the second time in this month to discuss on the upcoming respiratory viral diseases. We have amidst us Dr. Girish Mathur, President API, Dr. Muruganathan, past President API, and my good friend Dr. Ishwar Gelada, AIDS man of the country. I heartily welcome them for this program. Dr. Ganga Kedkar is here to discuss on the newer respiratory viral diseases. And we have the faculty, Dr. Murali Mohan, Dr. Rabindra Mehta, and Dr. N.K. Singh to discuss on the viral diseases. Our APA state branch is represented by my good friends, Dr. Maya, Dr. Govind Babu, Dr. Ravi Kirti, Dr. Vishwanath are here. Dr. Alshetty and Sagram are actively involved in organizing this program. Many respiratory viruses have made their appearance in the recent decades in addition to flu and measles, such as Nipah, Zika, hantavirus, Hendra virus, SARS, and MERS. After COVID-19, the country is witnessing the attack from the influenza. Influenza type A viruses have been classified into subtypes on the basis of the combination of different viral surface protein, hemagglutinin, and neuraminidase. There are 18 different hemagglutinin subtypes and 11 different neuraminidase subtypes. Based on the origin host, influenza A virus have been classified as avian influenza, swine influenza, or other types of animal influenza viruses. Avian influenza, that is bird flu, includes the virus subtypes H5N1 and H9N2. Swine, the pig flu, virus subtypes include H5N1 and virus includes virus subtypes H1N1 and H3N2. And this animal influenza type A viruses are distinct from the human influenza viruses. Seasonal influenza is an acute respiratory illness caused by the influenza viruses found in all parts of the world. In India, there are two peaks of seasonal influenza, one occurring between the January and March, and the another following the monsoon season. The Integrated Disease Surveillance Program and the Integrated Health Information Platform have reported 3,038 laboratory confirmed cases of different subtypes of influenza, including H3N2 till May 9, 2023. Around 451 cases due to H3N2 subtypes have been reported across the country from January to March 5, 2023. Patients presenting with intense cough lasting over a week, coupled with fever, can be linked to the influenza A subtype H3N2. H3N2 caused the 1968 flu pandemic, and the year 2018 was the 50th anniversary of the influenza A pandemic. Though its morbidity and mortality were significantly lower than 1918 influenza A H1N1 pandemic, influenza A H3N2 subtype virus has been appearing as seasonal influenza illness since then. And H3N2 is a non-human influenza virus that normally circulates in the pigs and may infect humans. Symptoms are similar to those of the seasonal influenza flu virus, manifesting in fever, respiratory symptoms such as cough, runny nose, possibly body ache, nausea, vomiting, and diarrhea. One has to take precautions similar to those followed during the COVID times. Indian Council of Medical Research surveillance has found among the patients with H3N2 flu, fever, cough, breathlessness, and wheezing are the common clinical features. 16% of them had pneumonia and 6% seizures. Nearly 10% of patients with severe acute respiratory infections needed oxygen and 7% intensive care management. Initially, India recorded death of 2 persons, one in Hassan district, Karnataka, and another in Jind district, Haryana, due to influenza H3N2. The former was 82 years old and with comorbidities, and the later 52-year-old with liver cancer. Third casualty was in Vadodara, a 58-year woman in Gujarat, and a 23-year male medical student in Ahmednagar, Maharashtra, succumbed, and another, age 73, died in Pune, and more than 9 cases have died in the country with this infection. The mortality is high among the elderly and the individuals with comorbidities. The studies made on the effectiveness of H3N2 influenza vaccine has failed to provide an effective resistance for all age groups due to the rapid evolution of the influenza virus. The observational studies have shown that the influenza vaccine effectiveness is lower for H3N2 relative to H1N1 and type B. Antigenic evolution has facilitated H3N2 to exhibit immune escape. Further, increasing glycosylation of the hemagglutinin shields antigenic sites from antibody binding. Egg passage adoption of the vaccine viruses creates mutations that bring about changes in glycosylation, impairment of the neutralizing antibody response, and reduce vaccine effectiveness. Antiviral agents such as neuraminidase inhibitor, oseltamivir, reduce the viral replication and its replication. It has to be administered within 48 hours of the onset of symptoms. Early initiation of the drug shows beneficial response, and it has to be given for a period of 5 days. The country has passed through the worst pandemic of COVID-19 and is witnessing new respiratory viral diseases. We have to take precaution to prevent them, and we have to take adequate precautions, and we have assembled here to hear more about them from the experts who have joined from Dhanbad to Bangalore. Dr. Ganga Kedkar is with us, and we are eagerly waiting to hear them, and I am happy to associate myself with the inauguration of this program, and I wish the deliberations all success. Thank you.
Thank you, sir, for your kind words of wisdom and sparing your valuable time to deliver. I request Dr. Muruganathan, sir, to address for a few minutes.
Good evening, everyone. I think that the topic of the day is very relevant because we got so many virus now. We don't know which is what. So I think we'll listen to the wisdom of Raman Kangwalkar, and of course Shankar gave a very, in fact, he gave a very good, overview of the whole condition. So I wish the function also program all success. Now over to you, Sangara.
Thank you, sir. Thank you for sparing your time to join. Since Dr. Girish Mathur is held up, we'll move on to the scientific session. I request Dr. Murali Mohan, sir, to take over the proceedings for further. Dr. Murali Mohan, sir.
Thank you, sir. That's very kind of you to invite me for this very important session. And who better to take us through an update on the new viruses than Dr. Raman Ganga Kedkar. He has steered us through the COVID program. He has steered us through the pandemic with not only, as you said, sir, advice to the government, which is very valuable, but also coming on TV frequently and calming down people. The two names we associated most with the pandemic, the common public, the general public associated panic. One was Dr. Randeep Guleria, former chief of AIIMS, and Dr. Raman Ganga Kedkar, who brought their wisdom to us. We are now seeing an upsurge in viruses recently. We went through a lot of unknown viruses, but specifically, we are seeing an upsurge in flu, mostly H3N2 from what we gather. We are seeing an upsurge in COVID over the last week. There has been a surge, had 155 cases in Karnataka yesterday with 1 death. And of course, we are seeing a lot of adenoviruses. A colleague of mine went down with adenovirus recently, and they follow very typical patterns. And one of the problems we always know is that viruses lay open the road for bacteria to enter and cause pneumonias. Without any further ado, I'm going to request Dr. Ganga Kedkar to speak to us on the upcoming respiratory viral diseases. Sir, over to you.
Thank you, sir. Let me first thank Dr. Biradar and the entire fraternity have invited me to speak on this particular issue. And let me also apologize that the title that I gave was very inappropriate and confusing. So what I'm going to do today is to try and understand the viral storm that we are currently witnessing in India. Now, if you recall, no, the first thing that started striking us more often, you heard about adenovirus. There were all kinds of headlines that were emerging that in West Bengal, adenovirus is causing. Am I audible?
Yes, sir. Yes, sir. Yes, sir.
Adenovirus is causing a major challenge and was stretching the healthcare system tremendously. By March second week, 19 children had died, and almost thousands of hospitalized in West Bengal with adenovirus infection. So first we start with adenovirus, and the reason why I'm also doing it is we try to look at the other two diseases and certain commonalities in the approaches to raise issues to understand how we may have to deal with those particular viruses. When it comes to adenoviruses, one must remember it's a DNA virus. You have 57 antigenic types which are divided into 7 groups. These are labeled as from A to G. Subgroup that belongs to C viruses persists for years in tonsils and adenoids. Generally, this is a self-limiting illness with symptoms that are flu-like, and these symptoms are very difficult to distinguish, excepting when you have conjunctivitis, which tends to occur in an outbreak kind of a situation, which we will see subsequently. There is the reason why we have to worry about this particular syndrome is last couple of years we have been hearing a lot about sudden onset of severe acute hepatitis that tends to occur among healthy children and which is associated with very high mortality rate. And 10% of these children, if you look at the global data, they required hepatic transplant even in childhood. Now that's something which is very serious, and that's the reason why we have to learn a little bit more about this particular infection. Now, if you actually look at the data, all these children who had severe acute hepatitis, despite being healthy, they're found to not have any of the hepatitis viruses. They didn't have EBV, CMV, neither HIV, but 74 out of 169 were found to have adenovirus of some kind. Right? Of them, 18 out of those 74 had adenovirus 41. And what is worse is 19 out of 20 had both COVID as well as adenovirus infection. So we don't understand much as of now with respect to this particular outcome that we are seeing of presence of adenovirus as well as co-infection with COVID. And that's something which is serious, and we need to worry a little bit about those issues as such. When it comes to adenoviruses, we know what is most troublesome, the mode of transmission. You have droplets as a mode of transmission, fecal-oral route as another one, because diarrhea of the manifestations, poorly chlorinated water, and fomites. And fomites tends to create a lot of problem in terms of hospitalization, because then in those cases, isolation needs to have strict hygienic practices that are followed even in the hospitals as well as the clinics. Incubation period, it ranges between 2 to 14 days. And when it comes to secondary attack rate, it is as high as 50%, which means, it would largely infect even within the family, something which is a worrisome issue. When you look at clinical syndrome, as we said earlier, there are 57 subtypes of this particular virus. Now, when you look at these common types that you find, their clinical syndromes can be divided into those which are associated with different manifestations. Those which are endemic respiratory, which may not bother us as much, but when it comes to epidemic respiratory, which we have witnessed in Bengal, you find that the common types are 7, 14, and 55. among children. And we will come to know the significance subsequently of one issue that among military recruits in USA, they found it tends to cause a severe respiratory disease, and generally that is associated with the subtype 3, 4, 7, 14, and 21. And you see different kinds of manifestations that tend to come. But what is most important for us to understand, we need to perhaps augment our research efforts to develop vaccine against those strains that produce severe illnesses, especially the ones that we talked about acute respiratory disease, epidemic respiratory kind of a syndrome that tends to present to you, and then hemorrhagic cystitis. That is something which should be a major research priority now. When you want to diagnose this, you could do antigenic test, you could do serology. Culture is as much difficult, but PCR perhaps is the safest way to diagnose, and currently multiplex PCR is also available for the same. So when it comes to treatment, you find there is hardly anything that we have. You tend to provide symptomatic support that you could provide to management. You may provide fluids. You don't provide antibiotics until the time perhaps you have some evidence that there is a superadded bacterial infection. There are no known antivirals that works against adenoviruses per se. Now, why should we be worried about adenoviruses? Adenoviruses are also implicated in with certain malignancies that people tend to develop, that is hepatocellular carcinoma and cervical carcinoma. They are associated with oncogenesis. And that's something which is a major worry that we still have lingering at the backdrop when we think about adenoviruses. Do they add to the risk, which could be also enhanced by our own genetic factors, which may influence? That is a question we still need to answer well. But what is also important is adenoviruses have certain benefits that we are currently using them. If you see adenoviruses, we know that there were at least 4 vaccines which we have used during COVID time, where we used adenoviruses as vectors per se. If you look at which strains, if we try to recall, it was adenovirus 5, adenovirus 26, and also the chimpanzee's adenovirus, which we had used. And gene therapy is the newer approach that is likely to come, is also going to use adenoviruses. So adenoviruses are extremely crucial in terms of what we should be understanding with this particular virus. Now, why am I stating this? If you look at the vaccine that is available against adenoviruses, one must remember that this vaccine is only provided to those who are in US military. This is a live vaccine, and which is based on AD4, that is adenovirus 4 and adenovirus 7, which are known to cause severe infection in US military. And this is an oral tablet that is given. There are 2 tablets, one of AD4 and one of AD7, and that is given at one time. This is not to be chewed, and it can only be given because the clinical trials restrict that age group to 17 to 50 years of age. The efficacy of this vaccine is almost 95%. This is also based on antigenicity rather than true data that could emerge as such. These people who receive this particular live vaccine need to follow good hygienic practices because the virus is shared almost 28 days through the feces per se. Is there any side effect that is associated with it? Perhaps the most important one could be severe headache that may become important. Why did I show the earlier slide where we looked at the vaccines that are useful, and then you look at adenoviruses which are associated with oncogenesis? The reason is, if we think in terms of using a vaccine that is powerful against adenoviruses, perhaps we may also compromise the usage of adenoviruses as vector or as a vehicle to provide gene therapy. So that dilemma will continue to exist, and therefore we may have to choose only those which are associated with severe disease per se, which could challenge all of us. Now, what is a major issue here? At a time when we are facing these three viruses, there is certain thing which we have to understand. Here, this infection is largely due to droplets per se. Now, what implications would it have? You have COVID, which is largely airborne, and now you have adenovirus, which also has droplet infection as its mode of transmission, and therefore it becomes very difficult to even think, because we have almost given up the earlier hand hygiene practices that we were following rigorously during COVID pandemic per se. But what is the implication? You need to isolate these infected individuals, especially in the hospital and the hospitals when you admit them. You have to wash hands like we talked about during COVID time. Avoid touching your eyes and nose. Hand hygiene also against fecal-oral routes, and avoid close contact with people, those who are sick. Now, why does this become important? It almost makes it certain that if you are handling these patients in the ward, the likelihood of secondary transmissions occurring within the setting is always going to be higher, especially to the healthcare practitioners. Now, this is something which is important from adenovirus perspective. Then suddenly we started hearing about the reports of H3N2 infections in India. Now, if you actually look at the numbers that have come, when it comes to those that have been reported until 28th February 2023, a total of about 955 cases have been confirmed. Tamil Nadu had the highest number, 545. Maharashtra has 170. Gujarat has 74, and small numbers come from Kerala and Punjab. Now, why is it that we repeatedly tend to see these numbers being reported higher in southern states? Perhaps that's a reflection of the access to health and the awareness that tends to exist in people, and therefore these numbers tend to be seen perhaps little more in the southern states per se. All of us, as Dr. P. Shankar did describe rightly, there are four groups of these particular viruses. Type A, the major worry is with the subclade H1N1 and H3N2. H3N2 is comparatively milder in terms of severe outcomes like deaths that may come compared to H1N1. But type B, you have Victoria and Yamagata. Now, all these strains are used for for provision of vaccine every year. Now, what is important for all of us to understand? When it comes to attack rates are more like incidence of influenza among, let's say, children. Now, if you look at overall incidence that could occur among children, it's almost 22% of them are likely to get infected during influenza season. When it comes to what proportion would perhaps be found to be having symptomatic infection, you will find that about 13% of them are likely to be 13% of the total are likely to be found as symptomatic, which means 9% of those who are infected may remain asymptomatic per se. When it comes to adults, you will find this number goes down. You will find that the incident infections, which is not a good term to use in these circumstances, but we call it as secondary attack rates. It's about 11%. Overall secondary attack rate is 11%. And then when you look at symptomatic infection, it's only about 0.4%, 4%. Which essentially means among adults, it tends to be little milder. But when it comes to the older population, you find 7% of them are likely to be symptomatic. If you compare with the earlier figure, it was only about 4%, and therefore there is a worry of getting this particular infection and adverse outcome becoming more common. Most often, this flu-like illness, which we call as influenza-like illness, ILI, tends to present with milder flu-like symptoms, which are very difficult to distinguish per se with any common cold that tends to come, excepting perhaps high-grade fever that may suddenly start with cough without any giving you any lag period per se. But there are certain warning symptoms and signs that may warrant, especially among the at-risk groups, those who are young children, pregnant women, and elderly persons as such in the society. If they develop pneumonitis, any bacterial co-infection, if they present as encephalopathy, dehydration, or there is an evidence of cardiac involvement, then in those cases, this warrants admission per se. Now, if you look at diagnosis can be done, you have to done easily with RDTs or RT-PCR. But there is one thing which we must remember, we should avoid use of serologic tests, and that's something which is critical for us to understand. Now, I'm not going to dwell more on the drugs, which all of us know. All of us know that you have oseltamivir, then you have zanamivir, and peramvir is not available currently in India. Zanamivir continues to be available. But what is the utility of the same? If you look at this, they reduce hospitalization by only 1.5 days. And that is also if you start it within 48 hours of symptoms. Now that poses a greater challenge as to who will you provide these particular drugs per se. Now, one thing which is little important for us to remember, that those who belong to high risk groups perhaps should be provided these drugs earlier within 48 hours of symptoms, and that may be little helpful per se. Now, one of the things which we have to remember, now this is a graph, I don't know how much of it you are able to see. This is a graph which is actually on a time scale from 1995 to 2020. The vaccine strain which we had chosen and the infection that was actually seen, the circulating strains that were seen, the difference that you see between circulating strains and vaccine strains. The ones which are vaccine strains are essentially seen in greens. Now, what do you essentially make out of it? There are differences in vaccine strain and circulating strain. Now, why does this happen? This happens because RNA viruses mutate very rapidly, and the vaccine composition as to which strain would you pick up and add that to the vaccine is based on a model data from model data that tends to be scrutinized sometime in the month of February of every year. And there are two different seasons in India, which Dr. Shankar did allude to, and you will find different strains tend to mutate and perhaps predominate in that particular period. And one also has to remember that India falls in the center of northern as well as southern hemisphere. So for India, that becomes a truly challengeable situation per se. If you look at vaccine efficacy of influenza versus H3N2, what is it that you essentially find? That you will find that vaccine efficacy tends to vary by age. The older you are, the vaccine effectiveness tends to go down, and which is something which is a worrisome issue, because we are worried more about elderly, but vaccine effectiveness has repeatedly been shown to be little lower among older populations per se. Now it is also important for us to remember that there is a new data that is emerging, that those who have received repeat vaccine, that becomes a major issue, because a repeat vaccine, if you actually see in this particular graph, you will find that the vaccine efficacy against H1N1 was 58% in the current season. And if I have received the vaccine in the last year, then I would have a vaccine efficacy which would be lesser. It would be perhaps lesser to 53%. So it loses close to about 9% of vaccine efficacy. And what is worse is with H3N2. In H3N2, the vaccine efficacy tends to come down to close to about 20% if I have received the same vaccine in the previous season as well as current season. But that poses a big dilemma. Then what do you do? Because if the vaccine efficacy against H3N2 is way less than 40%, which is normally used as a cutoff to recommend vaccine, should we provide it or should we not provide it? Now, we need to remember one thing, though it tends to diminish, it is better to give than nothing, but there are implications for vaccine delivery. This particular vaccine should then ideally be given only to those who are high-risk individuals, and that's one issue that we have to remember at this point in time. Now, when it comes to providing this particular vaccine at a time when somebody was already infected with SARS-CoV-2, that is COVID. Now, what is it that you find? If you look at real-time data, there is certain small variation that you see in the data points when you look at enrollment of different cohorts. But by and large, one could make a statement that if you are SARS-CoV-2 positive, the efficacy tends to go down. The reasons are unknown at this point in time. Is it a reflection of people not taking the vaccine and they had just had the infection from SARS-CoV-2 is something which is still debatable per se. The vaccine efficacy, a meta-analysis in order to solve this particular issue was done, and they tried to find out whether vaccine efficacy declines among those who had COVID earlier. And there is a clearer evidence that you see right at the bottom that those who had COVID infection, especially among the older population, you'll find the vaccine efficacy against H3N2 drop down dramatically. Now, what do we do in India? You have a influenza surveillance which is established in 30 VRDLs in India. Now, we use a certain respiratory panel to try and understand emergence of different respiratory pathogen. One is from influenza A, you have H1N1, H3N2. From influenza B, you have Yamagata and Victoria. You have RSV virus. You have metapneumovirus. You have parainfluenza virus, respiratory adenovirus, and rhinovirus, against which we tend to collect some data. Now, what was happening but during COVID pandemic? Why were other respiratory viruses not seen during COVID pandemic? Perhaps it's a function of higher transmission. When a competition tends to occur between different organisms, an organism that tends to rapidly spread, has a high transmission efficiency, tends to infect more, and therefore perhaps the infections of related to COVID were more often seen than rest of the infections as such. And it is also a function of adherence or non-adherence to COVID appropriate behavior. And this is very clearly seen in the slide that you are seeing. You are essentially seeing that in 2021, it's sometime around June, when the COVID appropriate behavior started dropping down, you find that the influenza started striking at least a small number. The ones that you see in green color at the bottom on the left side were found to be increasing at that juncture. Subsequently, what happened? You had H1N1 that tended to come little more. And as COVID started increasing, again, you find that H3N2 has also been seen commonly. So essentially, what does it mean? From whatever data, we could see that if people don't adhere to COVID appropriate behavior and major population had been infected with Omicron variant, you find again these influenza viruses have started striking little more in the country per se. Now, this is about influenza, but people tend to get worried because now you hear about XBB 1.16. The fear that people tend to have, including policymakers, is will this lead to emergence of pi? Because now we are likely to be past Omicron, and the next alphabet that tends to come is P. So perhaps the name of the new organism that may come will be Pi. Would it emerge soon in India? Now, there are certain things which we have to try and understand. In India, we started doing surveillance, genomic surveillance. When we do genomic surveillance, one of the things which becomes important is you need to develop communication strategies for layperson. Why am I stating this? Every kind of a mutation that you see, a new variant that is being seen, is reported in lay press. What does it essentially do? It puts off people because their trust on those policymakers or on those who advise taking vaccine tends to go down because they don't create so much of difference. They are at its worst, they are variants under monitoring rather than any kind of a threat for public health system. Now let's look at what is actually happening. The viral fitness is increasing dramatically, as you are seeing on the right side. If you look at the top, you will find that the fitness has increased so much that that has become a permanent feature of this particular Omicron variant per se. If you look at phylogenetic tree, you look at XBB variant, which has emerged from BA.2 as such, you will find that it is far distantly located from BQ1 or BQ1.1. Now, this particular issue is becoming more important. As we discussed the last time, this is a convergent evolution because this is occurring within the same Omicron variants family or sublineage, and you are seeing all kinds of variants which are actually part of the family. And therefore, any time when you look at these variants, you will see a different name coming up or different label tends to come up. It all depends on different parts where you are actually looking at. Now, if you look at the global data on variants and if you give them different colors, you can't make any sense out of the variants data. And the reason is you see so much of diversity. The reason perhaps is the numbers that have been screened, the frequency of testing that has been done, the reference time, when these events have occurred or when the tests have been done, and how generalizable is the data. That's something which is a major issue when we look at genomic surveillance data per se. But one good thing that has happened is these variants continue to remain part of Omicron variants. They're not affecting lungs as much. So tissue tropism continues to lead to milder infection among them. Now you look at what has happened in years. In 3 years, we have accumulated 74 amino acid mutations and 32 are spike mutations. And essentially what you are seeing is the movement that goes on the right side where the virus or the variant tends to appear as entirely different from that we had seen earlier. Now, if you look at the spike protein and try to put up the map, what is it that you find? When you look at XBB 1.5, the red one at you will find that there are almost very little spots left to mutate at this time point, and therefore perhaps it leads to a conclusion that may come among people's mind that perhaps we may not see more evolution occurring in terms of these viruses over a period of time now. Now let's look at the global averages of 7 days moving averages, where 10 different countries tend to top in new reported infections. You suddenly find that still doesn't figure in the same. The reason is we already had Omicron infection, and in Omicron, there are certain issues which we will have to remember that we had BA.2, which was a predominant infection that occurred over BA.5, and therefore we continue to remain protected. Where are we today? If you look at daily new infections that are occurring, they continue to remain at a lower scale. You will find that even today we are reporting anywhere between 900 to 1300 per day. And you have to also remember that perhaps these increase that is being picked up and talked about by people is occurring because you have H3N2 or influenza, you have adenoviruses, which lead to lead to these people going to a healthcare provider. And when it comes to testing, healthcare provider test them for both, no? Whether it is H3N2 or whether it is COVID, and you are actually picking up more number of infection. Otherwise, these people would not have it come to you. So it is essentially something which we have to understand. Now we are into a stage where absolute numbers of new infection doesn't remain a reliable indicator. The reason is, if you have poor health-seeking behavior, people don't come to you when they are symptomatic with COVID. If you look at the fact that you have made home testing possible, and when that happens, people may test at home, people may neglect completely because they may just say that this leads to milder infection, so I won't come. So what should be done as of now? As of now, in order to look at the severity of this pandemic, you have to look at hospitalizations and death. And where are we in terms of hospitalization and death? They are not increasing as much as of now. So what is it that we have to keep at the back of mind when we think of XBB 0.1.16? It's a recombinant of BA.2. You must also remember, by and large, recombinants are unlikely to spread rapidly because this is an accidental event and not an evolutionary event as such, which we must remember. These are largely reported from India alone, whereas rest of the world is reporting XBB 0.1.15 per se. And if you look at the data, you have between January to March 23, you will find that a total of 344 were found to be positive for XBB 1.16. We do not know the denominator because that denominator is still not available. No, when it comes to, or it's not there in the public domain. Which are the states where they have reported XBB 1.15? It's Maharashtra, Telangana, Karnataka, Gujarat, and Delhi, all having better healthcare infrastructure, and therefore perhaps it is being picked up at this point in time. What is also important for us to remember that if this virus has been present, variant has been present for last 3 months, no, still it has not spread dramatically over last 3 months. If the spread was to occur dramatically, you would have had perhaps seen larger number of people coming down with this infection. And what is also important for us to remember that there is no increase in hospitalization, no increase in death, and this variant continues to be part of Omicron family. And today we are almost 16 months within this Omicron family's different variants that have come up. So essentially, it may not pose a major kind of a threat per se. You look at US data. US data that is reported by CDC tends to show you that there is no new variant that is emerging. For them, it continues to be XBB 1.5, which is most commonly seen. But is that, when we talk in terms of variations, one must also remember that when an infection tends to become endemic, the overall scenario can mislead. And why am I saying mislead? This is a typical US graph that you are seeing of different states. And if you look at which ones are predominating in different states, you will find there are differences there. And why would these differences occur? Because if majority of the population in US, it is assumed that 85% of the people have already been infected by Omicron virus so far. So essentially, those 15% who are going to get infection and finding out vulnerable people within their own contacts, social contacts, are likely to vary, and therefore a uniform picture to come may not occur, mainly because our social contacts, the size of those social networks will perhaps decide which one is likely to predominate, which is very difficult to, very difficult. I'm sorry. What am I doing? Very difficult to actually speak about and attribute to from epidemiology point. When it comes to XBB 0.1, 0.16, which is reported and worried about in India, you will find those numbers continue to be very small. And you have to remember, US continues to have a very high number of samples which are submitted for genomic surveillance per se, which essentially means even there, from October 2022 till March, the numbers did not rise much. So you are unlikely to find that the situation will differ in India per se. Now, one of the things that we have to understand, most often when we look at variants, we used to classify them as variants of interest, variants of concern, and variants of high consequence per se. One of the things that is happening with Omicron is Omicron infection has been so mild. Now people know for sure that you perhaps may not enter into variants of high consequence at all. What should remain relevant when you are continuing to evolve within the space of Omicron per se? A new term has been coined now, VUM, that is variant under monitoring. And if you actually ask me, uh, to me, it is premature to infer that XBB 0.1, 0.16 is even a VUM because there is no lab data which tends to suggest that this is actually happening to be classified even under VUM. So this is one, to me, this is one variant which is part of this convergent evolution that is occurring. But some may wonder why US continues to suffer. Even today, they have daily 10,000 plus new infections reported, deaths, about 138 deaths every day, and they have mostly XBB 0.1, 0.5. The possible reasons are most of them, their older population tends to be, compared to India, they have a higher proportion of the population that is of older age. You have immunocompromised patients belonging to different, they may be malignancy patients who have received all kinds of interventions and they continue to live. At least 15% people had COVID. Terminology that has been used recently by Dr. Ryan, that those who did not have COVID, he called it as Novid. The booster coverage above 65 years of age is just around 40%. And COVID appropriate behavior has gone for a toss even among those who are older persons. Now, is there sufficient evidence to say that it continues to challenge the system? You look at wastewater sewage data that tends to emerge from US, you find there is a small bump. See, even now in 2023 on the right side, and which essentially means they are continuing to face this problem, and perhaps this problem is going to last longer. And all of us know that COVID has not disappeared. COVID is unlikely to disappear completely, but it will end up into an endemic kind of a situation where focal outbreaks will be seen commonly among people. Now, when you talk of endemicity, when endemicity will occur one way or the other, what are going to be its implications? You might perhaps find COVID from non-seasonal infections would perhaps also have some kind of a seasonality that is associated with it. And perhaps you are seeing the co-infections leading to this infection more often, which we will see subsequently why. Viral interactions that tend to occur, you will find that there would be an interference of co-circulating viruses, and perhaps the outcomes will also differ in these different viruses that will act together, as we have seen with S3N2, where the risk tends to increase when it tends to occur together, especially with respect to vaccine protection. Hybrid immunity, the recent data that is emerging all the time, is it works well until 6 months after infection or vaccination. But you have to remember this is only 6 months data. But there is now a new emerging evidence that the protection via T cell, if you model that particular level of protection, may perhaps last over 3 years period. And that's a good news for all of us to think about. We need to adopt a better lifestyle with masks. We must remember using a mask in a community setting reduces the risk of transmission by 90% and the risk of acquisition by 30%. In order to strengthen, then why is the government resorting to mock drills in the hospital? It is perhaps to ensure that we maintain our investment in proper manner, especially that related to equipment, investment that has gone into training healthcare manpower per se. What is new and important to learn today in COVID? Since we are talking of this issue, perhaps it would be an opportunity to think of looking at certain evidences that are emerging. Now, most often we were always worried whether we should also take a bivalent vaccine, especially those who used to go to US. They used to ask a question that I have received a monovalent vaccine in India. Now, should I take bivalent vaccine? But if you look at this particular data, you will suddenly find that if you take bivalent vaccine, you will also find that bivalent vaccines take is comparatively lesser. It is more for those which were earlier infections, but when it comes to Omicron, it tends to be lesser. And this becomes all the more clearer in this particular study, where you find that the ones on the right side, I'll describe the graph on the right side. There you will find that it is the protection appears to be better based on immune profile, that D614G had the highest levels compared to BA.1, BA.2. You look at the Omicron variants that tend to come even when you are provided with a bivalent vaccine, where BA.5 was also used as one of the, BA.2 was used as one of the strains per se. Is that true? That these differences tend to exist? If you look at the estimates of effectiveness, you will find that the estimates of effectiveness, whether you, let's take Delta, you will find for infection, it got reduced to 69% against AstraZeneca vaccine. But once you talk of Omicron, it went down to 36%. Right. So the same vaccine, if you compare, for the ancestral, that is Wuhan strain, the alpha, whichever, you will essentially find that the effect tends to be lesser, the effectiveness tends to be lesser, but the same vaccine, actually, even if you provide as a booster, you will find that it will have a better impact against the older viruses. Now, what is it that we are observing? Is it what is called as Hoskins effect? It was also then, when it was observed in influenza, it was called as the original antigenic sin. What does it essentially mean? If I receive my first dose of a vaccine which was based on Wuhan viruses, you will find that since these Wuhan viruses were closer phylogenetically to the strains that came up to Delta, you will find that even if I give a booster, the first effect that the vaccine produced against Wuhan virus would be actually witnessed subsequently. You will find that the vaccine that I am providing, whether it is a bivalent vaccine, this bivalent vaccine will continue to produce a better response against earlier variants compared to Omicron variant, which was one of the strain that was one of the variant that was also used in the vaccine. So this was seen in influenza, perhaps also occurring even in COVID. So you need to augment your efforts to conduct vaccine research against these diseases. How long this trio is likely to pose challenge in India? COVID is unlikely because basically the hospitalizations continue to be low. adeno and H3N2 are more of a seasonal viruses. But the bigger question that we have to answer is, would climate change threaten this year worse if the seasonal changes that are expected to occur do not occur as smoothly as have been occurring? Perhaps, the speculations that this may go in next 2 weeks' time may not come out as true. There are people who started wondering whether pi will emerge in next 2 years in the world. They did a Delphi. 10 scientists sat together and they did a Delphi whether the pi will emerge in next 2 years, and most agreed to 10 to 20% as a figure, which to my mind is also an overestimate. And why this 10 to 20% as a figure? You have to remember that when Omicron came, there are three theories of origin. One, it actually came up, mutated in a closed society, and then people actually came. So we do not know why the earlier sequences were not picked up and were not picked up. Then there is a ping pong match that this virus actually got infected human beings from animals, and then animals also infection from human beings, which was also transmitted subsequently to human beings. This is called as reverse zoonosis. However, there is still no evidence, direct evidence to suggest that people have acquired Omicron or its related virus from the animals subsequently. So we know large number of animals are susceptible. When it comes to immunocompromised hosts, those who are HIV infected, transplant cases, people that the virus will survive longer in them, and that's why a new variant can come. Now, this particular thing has been proven based on only one case report that has emerged. However, we don't have a direct event whether that kind of virus can jump again back into human beings per se. But there is a new concept that is emerging. Those who have long COVID, they also are likely to have uh, virus replication ongoing within the body for a longer period per se, and become a key issue to understand. Some people tend to feel that the proportion of almost 10 to 15% people are likely to develop long COVID can be a threat that newer virus may emerge, newer variant may emerge. But what is more important to remember, as I say, that there is no evidence that such a thing can jump from one individual to another. But this remains an important issue and an issue to be researched, whether provision of certain drugs cause this replication, even among those who have long COVID, may be beneficial per se. And why does this become important? Because all of us know post-COVID is associated, is likely to be associated with one or more infection. The more the number of COVID infections that occurred, the risk of development of long COVID tends to be high. Oh, sorry. And if you look at the spectrum of long COVID, it's really scary. As of now, you look at multiple organs getting infected and different dysfunctions occurring in those organs. So one of the issues that is becoming important is conducting research on how to prevent or also treat those infections. What is new that has come? If you want to prevent long COVID, even if a person has Omicron infection, provide metformin in OPD. Now, what is important is this reduces the risk of development of long COVID by almost 42%. But the dosages that have been used in this trial, we don't know the logic as such. This is generally to be provided in mild to moderate cases among at-risk population. Metformin has been used for 2 weeks per se. On day one, they give only one 500 milligram tablet. Day 2 to day 5, it was 2 tablets. Day 6 to day 14, they gave 500 milligram in the morning and 1000 milligram in the evening. But this reduction is easily possible if we believe in this particular study report that you could actually do it among those who come out to be positive, who are picked up even this in this season because they had fever per se. So, though there is a small risk that a new variant may develop and lead to a resurgence of COVID-19, we need to be more vigilant and we are better prepared at this point in time. Adeno and H3N2 are typically seasonal in nature. We may need to adopt a lifestyle where we use mask in risky circumstances, at least by those who are at risk, and try and follow the greetings the way we do, and perhaps we would have some reduction in new infections that may occur for different organisms. Thank you, sir.
Thank you so much, Dr. Gangakekar. That was the usual masterly talk that you give, full of information, a lot of new information for most of us, and a lot of enlightenment. First of all, let me invite our panelists, Dr. N.K. Singh, Dr. Ravindra Mehta, whom we've spoken to earlier, and Dr. Gilada, who joined us also. Welcome to all of you. Dr. Sangram Biradar, would you like to say a few words before we start?
No, sir, you carry on because Dr. Gilada is in a hurry to join another meeting with the office. So
Yeah, I
kindly,
think,
kindly discuss. Yeah, he's joined.
Yes, I saw he's traveling, and I
Yeah.
think Dr. Ravi Mehta also wants to leave early. So
I will join in after 5 minutes. Huh?
Sure, sir.
I'm in car. I'm listening to all of you, listening to Gangakekar. I'll join after 5 minutes because then I will have stable connection.
Sure. So, Dr. Gangakekar, you spoke to us about, the standard 3 that we're looking at, adenoviruses, the influenza viruses with a focus on H3N2, because that's the new chap that's come up. And we are seeing some of H1N1, but we're seeing a lot more apparently of H3N2. And of course, you told us a lot about COVID and the Omicron and what are the changes that are expected. I'm going to ask Dr. Ravi Mehta first. Ravi, how much are you seeing of the other viruses? I'm sure you do quite a lot of the multiplex PCR in your ICU. One of the things we are seeing is we're seeing other viruses also. So, what are the other viruses apart from these big 3 that we're talking about?
So, Murli, it's an excellent question. And I think we started to look for this in the last few weeks when we realized that all these SARI-like illnesses were not actually COVID. So, you went through the exercise of look for COVID. There is no COVID. Look more for COVID, which we are so used to doing maybe. And then after that, we started to say, okay, fine, let's send off a swab. And then interestingly, technology has caught up with giving us swabs with the multiplex PCR where everything is getting combined. Otherwise, it's not a simple proposition to send multiple swabs. In that, we started to catch all these. Truthfully, I think what we saw first was the usual old culprits, the 2009 pandemic, famous rogue H1N1. We saw seasonal flu, the regular influenza, and then slowly this H3N2 started to catch up. Have in a single center area or 2-3 centers which we are, have we seen enough of H3N2 to reflect the country's experience? Probably not, truthfully. Have we seen other viruses? Yes. A bunch of these other viruses have been caught by the multiplex PCR, but again, we don't know the clinical significance. Adenos, RSVs and all. So they have been caught, and truthfully, as we skim through the report, we're actually looking for treatable viruses. So these, we have to go back and look at what was the actual prevalence of these, but they were there in bits and pieces. Critical patients I have not seen a lot, truthfully, because most of the PCRs were sent off a little late, and they were sent off from bronchoscopic samples, where we always worried about whether we're catching more than is actually there causing disease. So a long way to put down the way this has gone in the last 3 to 4 months, but the clinician will identify with this. But a spate of viruses, and one wonders on the billion-dollar question that why is this happening? Is it that one jumps the other, as was pointed out? Is it that our influenza vaccination, with all the caveats mentioned, actually did not have impact? And we know that when we talk vaccine in 2022, people only focused on the COVID vaccine. So is it that there was a significant decrement in the limited efficacy vaccine also? Many questions come up, which I'm sure you're going to bring up in this interesting discussion.
Thank you. I actually wanted to also ask, what is your experience with the human metapneumoviruses. We've seen quite a few of them. We've seen the para-influenza viruses. As you said, we don't know the significance, but unless we, pick them up, we're only going to call it viral infection other than COVID or other than influenza. So what do you think? And I'm going to ask, the other panelists to come in on this also, Dr. Gangakhetkar and Dr. Singh. What do you think is the importance of doing this multiplex PCR? It's one of the only ways we can pick up on what is actually happening inside. Clinical significant or not clinical significant, we'll discuss.
So I think again, history comes into the picture. Sorry, am I coming in or somebody else?
Yes, please go ahead, and
Yeah.
then we'll go to Dr. Gangakhetkar and Dr. Singh.
So if you look at it, and like Dr. Gangakhetkar pointed out, everything is taken in terms of historic perspective. Dial the clock back 2 years, we never did multiplex PCRs to this extent. So we have no idea what was moving around in the community. It was look for, if at all in a sick patient, the usual culprits. There was no COVID, it would be the usual flu, and we would stop out there. The multiplex PCRs have increased both in prevalence, availability, and economical viability in the last year or so. So we really don't know that what we see now is a finding which was there, which is being caught, as often happens in medicine, or is it a trend which is different? So that is one observation. Nevertheless, it is fascinating to see the number of viruses, and the last 3 years have been the year of virology to see how the emphasis has changed. The second thing is we're probably also interested in disease behavior. Is it restricted to one organ or is there multiple organs? So that becomes an interesting connotation when you try to combine the multiplex PCR result with the manifestation you see clinically. The third is obviously the outcomes, that if you turn only positive for any one of these, are they causing severe disease, which makes us go back to the books and figure out what was the actual prevalence of these mentioned in literature, which we never noted. And last but not the least is the implications for therapy. That what are we going to treat with? End of the day, even if you get these positive and you don't get the influenza negative, you will probably, and I will confess to this, wind up treating for regular treatable viruses. So this has been the interesting observation. I think this is the beginning of a metamorphosis. Epidemiologically, this is of course excellent and very, very fascinating. In the next year or two, as we try to rationalize our data and look at the multi-center, multi-city prevalences, we may be able to know the true impact of all these compared to what we saw before as an observational science.
Thank you. Dr. Gangakhetkar, the same question to you. What is the relevance of multiplex PCR? Would you advocate it? In serious respiratory illness, I'm not talking about somebody who just walks into the OPD. It's too expensive for that.
I know. No, there's one thing which I would bottom line as of now. The number of organisms that I showed for which multiplex PCR is done under respiratory panel is perhaps good for surveillance purposes rather than being interpreted one way or the other as of now. Now, which are the two? Because this we have been doing for last perhaps 5 to 6 years in those 30 sites. The number of organisms have been the same. Now, one of the things that we see is RSV is fairly more commoner as an incident infection. Now, one needs to focus on RSV because RSV vaccine is also likely to be introduced sooner. Now, we may have to work upon, do we have such a high incidence? We don't. Then metapneumoviruses perhaps are also seen as commonly. But as I said, it's not good to overinterpret that data unless a clinical association is seen. So how do we see clinical association? There could be two things that might happen. If I'm using such MPCR and in MPCR I pick up two different infections, perhaps whether this increases the severity of the already known virus, whether it is COVID, whether it is adenovirus, or whether it is H3N2, is something which would be perhaps a good clue that might come up at one point in time. The second issue is, I think we need to keep looking for abnormal presentations or unexpected outcomes that tend to occur and try to look at whether these things are occurring frequently in those situations that we have observed and we thought it could be important. But it is critical for the country to try and keeping a watch on all these organisms through surveillance. And now the entire surveillance network has been increased to 115. So we may have to think in terms of trying to involve more than 30 labs that we are currently utilizing, so that a clearer picture will emerge. One of the suggestions that I gave in National Task Force meeting on COVID the other day, I think we have to look at the functioning of VRDL. In VRDLs, whether we are trying to aim at finding new organism, or we need to focus more on burden of diseases of some vaccine preventable infections for which vaccines are being developed. Over, sir.
Thank you. Dr. Singh, as you know, was mentioned earlier by Professor Biradar, is one of the top educators in this country today through the various CME WhatsApp groups, which provide a remarkable amount of information, very scientific information. He curates these with amazing diligence, I should say, providing summaries, transferring from one group to the other information. So, Dr. Singh, I think you're one of the foremost educators in this country today. What is your opinion on this? Do you believe that we need more testing? We need more testing with something like multiplex PCR? What is its relevance in the context of, as Dr. Ravi Mehta was saying, most often we don't have treatments. However, unless we recognize that there is a virus involved, we will not recognize the links between one infection and the other. Dr. Gangakhedkar showed us that very good example of 19 of 20 cases with severe hepatitis, something you'll never think of looking for the connection between adenovirus and COVID, producing a problem. So we need to look at data also. While it may not impact our immediate care of the patient, I think it's important in the long run. What do you think, sir?
First, Dr. Murli, I'm sorry my video is not coming due to some technical issues.
No problem, sir.
So actually, today's talk of Dr. Raman is extraordinary. And the question which you are asking, Dr. Ravi Mehta also very nicely told what is happening in the real world scenario. But suppose if I take an example of the our state of Jharkhand, I think only 3 or 4 days before, we had a kit for this test. After when the lots of news came in the papers, then the state government rather woke up. So this is the most of the states, they have no such issues at present, that they are not aware even at many places. As far as as a physician, what I find that we are basically rather careful for the H1N1, and now the recent surge of this H2N3 which is coming up. Also there is a highly, I think this H5N1 is also making a news in some part, at least in US. We are not aware whether it is also will be a problem in India or not. I don't think so. But as far as you were told about the PCR testing, still in the most of the part of the India, it is not available at present. It is very costly. I don't think it is affordable at present. Most of times it is being done at the government setup. But even at my place, the Dhanbad, which is the coal capital of India, known as coal capital of India, this is not available at even at the medical college level. So what to tell about the private level? So I think we have to take a clinical eyes on what is happening. Most of the cases which are presenting like influenza-like illness, we should be aware at this time. But if you just remember the January talk of Dr. Raman, and he clearly told that time that the panic which media created about the surge of this COVID in January, I think, or December, Dr. Biradar, when they arranged this meeting, and he was so right, 100% right, to predict that nothing is going to happen again. In the same way today, his talk has given us solace that this is a seasonal variation. Rather, we should be more careful about to talk at community level about the immunity part. because so many things are there. Well, there are some compromised cases where the immunity is low. In that cases, even we should go for whether the selection of the proper influenza vaccine. Again, there is lots of where is not happening at the physician level about the influenza vaccine itself. People are asking day and night whether the present available vaccines of the influenza is going to protect you with this current variant or not. Although he showed, Dr. Raman has showed it to some extent, but recently there was a news that the GSK is launching a vaccine which will be very effective with this virus too. So there are lots of confusion too. Multiplex PCR has at present a very limited role in the ICU setup or in the hospital setup, not as a clinical practice. As far as a clinician, in my practice, there is not at all a surge of such illness in our part of the India. I think seasonal variation comes every time. Every year we will getting, but there is nothing like in the epidemic proportion at present. With these all things, I think also Dr. Raman has given a very important message about the drugs treatment. But as per CDC, the moment you suspect the patient is having this sort of influenza infection, earliest you should start the Tamiflu. So I would like to again hear about Dr. Raman, what is his view about this CDC recommendation. Thank you very much for giving this opportunity.
Sir, would you
Dr.
like to
Murali,
take
Dr.
that
Gilada has
question, and
joined.
we'll go to Dr. Gilada.
Yeah.
So, Dr. Biradar, you wanted to say something?
Yeah, Dr. Gilada has joined. I just wanted to.
Yes. I was going to him next. I'll just speak to Dr. Since Dr. Singh has asked a specific question, and then we go to Dr. Gilada. Dr. Raman, what is you mentioned it's most effective in the first 48 hours. So would you recommend giving it to everyone with, influenza-like illness?
Not everyone. I would perhaps only think in terms of restricting it to at-risk individuals. The sole reason is it's only going to reduce your hospitalization by 1.5 days. If it doesn't influence any other outcome that could be worse, one needs to think about it. But it's a question of choice that people may have to make. The second issue I would perhaps also speak about is unless you do this surveillance and find out, perhaps we would never have found out that vaccine against H3N2 is largely ineffective. It is only about 26% or so effectiveness per se. So we cannot and we should not forget about these smaller illnesses that we generally tend to think. The next thing which is also important is to look at adenovirus. There is no treatment that is available. But in last 2 years, there have been dramatic experiments that people have done since they started recognizing that adenovirus is perhaps associated with severe hepatic infection that can lead to even transplantation, hepatic transplantation among children who were healthy. People have tried Cidofovir, people have tried different drugs. It's only a question of giving importance, and you will find some answers tend to emerge over a period of time. So early case reports, early case series play their own important role in promoting research.
Absolutely.
Over, sir.
We learned that when the warning signal was started for COVID-19, with just a few unrecognized cases till then, that warning signal was given. Dr. Gilada will point to the AIDS pandemic, which started with a few reports of this unrecognized infection among gay men. Dr. Gilada, welcome. Specifically wanted to ask you, we've been talking about immunity, and you have been for the last 25, 30 years plus been dealing with what is largely an immunocompromised population. Are you seeing a surge in respiratory infections in this population? And what happened to them through the COVID pandemic? We're interested in looking at hearing about both those from you.
Thank you very much. Firstly, I must appreciate Dr. Gangakhedkar's talk. Very well projected. Unfortunately, I could not hear the previous 15 minutes of it. I started when he was projecting his X3 into slide first time. And a lot of his views and my view matches, not because he's a great scientist, but we have grown together, so we understand what is the scenario. Now, when you talk about immunocompromise, we found that HIV positive people who have been under treatment, they are no more considered immunocompromised. Their immunity is much better. We have seen also that among HIV positive people who are on ART, there were less and less hospitalization, less and less death among them due to COVID, rather than in their relatives, their husband, their wife who were not infected, who have been never under surveillance of doctors. There we have seen more deaths and more hospitalization morbidity there. Secondly, yes, those which are really immunocompromised are uncontrolled diabetes people, people with bronchial asthma, tuberculosis, which are having either not taking treatment or just put on treatment, and those other like renal patient, they were having the problems. But at our OPD setup, we do not get such kind of cases. Only in hospitalization cases, we see such kind of patient. So I don't have my primary experience of dealing with those immunocompromised people who could have been having this kind of problem, which is more significant than others. Now, coming to current scenario, is it confusing? Currently is a confusing scenario. There's a lot of environmental pollution, which is almost 300 AQI is there in Mumbai, Delhi, and many places. There are people who are coming with allergens. There are people coming with influenza, adenovirus, and COVID. So sometime when we find more COVID cases going up, let us wait and watch for another couple of weeks, because this may be just a targeted testing. As Dr. Gangakhedkar said, when a patient comes, we'll tend to do both the tests. And I would say that we tend to do only COVID test, because that is much cheaper than influenza test, which is costing more than 5,000. So in this last 3 years, we became totally COVID-centric. We never looked at other issues. We never developed influenza local vaccine. We never developed influenza PCRs in India. So we are all depending either for vaccine or PCRs of multiplex PCR only on imported kits and imported vaccines. So we should have looked at that. We should have energized our local industry in that, but we did not do that. Now, when we look at whether we should be really worried about XBB, XBB is an offshoot of BA.2. And ever since Omicron came in India, I've been saying that Omicron is a variant of support. I do not know why WHO has not created that kind of category, that only after Omicron came, everything opened up, everything started, there were less hospitalization, hardly any deaths, and now also is a tail effect of that Omicron. Okay, some bubble could be there. So I think XBB is not going to be of any problem to India because it is mainly BA.2, and it did not allow somehow BA.4 and 5. So those who had BA.1 and 2 and 3, they got BA.4 and 5 abroad. But in India, we did not get much of BA.1. We got BA.2, and we got stuck with BA.2 and few cases of BA.3. We never got BA.4 and 5. And wherever the current surge happened about 2 or 3 months before, they were all BA.5 surges. So I think India is in that way a comfortable position. Now the issue with the task forces is there is neither task, there is not force. And they are just becoming COVID-centric, and they just talk about, and one very good point Gangakhedkar pointed out, that our health science communication is very poor. And whatever is happening in the lab is going to the Google, and it's going everywhere. So I don't know why the things are reported in this way. Any kind of genome sequencing, that should be limited to a few scientists and not beyond that, maybe a medical circle. But everything goes in public. During the COVID, a lot of things were projected on television channels. As soon as you open a channel, the slides will come. If you get this, get admitted. If you get this, take steroid. And after everything was happening, over treatment, everything, but those slides were still there. So I think when we start health science communication, we made similar mistakes in HIV, we made similar mistakes in other diseases, and we unfortunately made similar mistakes in COVID. And we should not make those kind of mistakes again for flu or adenovirus or current XBB, that suddenly headline news comes from in Times of India, XBB 1.16 detected in India, first case, second case. There's something sadistic pleasure they are getting out of it. I don't know why.
No, I agree with you that there is probably too much reliance on, these headlines to project ideas on. But I think from what we are seeing, there is very little panic actually on the streets. You're not seeing people, in fact, sadly, people are not even taking standard precautions. Dr. Ravi Mehta pointed out that, during COVID, there was a failure to take the standard vaccines, which was a bad mistake. But I think what we are seeing now, this upsurge, is partly due to the fact that we've unlocked every precaution. Nobody's using masks. Nobody's taking the standard COVID precautions. Dr. Gangakekar pointed that out, that just adopting these precautions will help with a lot of these viruses. These are respiratory viruses. They are spread through droplet infection. They are spread from person to person. The theoretical risks of human to animal back to human is still a very, very theoretical point of investigation. What we can do, and we should be emphasizing, is the usage of masks. We have emphasized in the hospital, but still among doctors, we are finding that, usage of masks is still very low. I wanted to ask Dr. Ravi Mehta, Ravi, and we'll go back to Dr. Gangakekar after this also, is what is the impact of travel on, these infections? Dr. Gilada pointed out that, when we are seeing the American strains of the virus coming here, the BA 1.1, 0.2, and so on, these are often imported. What is the effect of travel on these viruses? What is the effects of the different vaccinations that they've had abroad and we've had here? Is that going to be a problem? We'll start with Ravi, and then we'll go on to Dr. Gangakekar to tell, to enlighten us on this. Ravi, are you muted? Should you be unmuted? Can we
think,
ask?
sir, he should be unmuted. Every co-host.
Yeah, you're actually
Yeah,
co-host. You can unmute yourself.
Ravi Mehta ka.
I cannot see Dr. Mehta. I think
He
he has
wants
to
to be
leave.
unmuted.
So we'll go straight to
Yeah.
Dr. Gangakekar. Sir, what is your opinion of the effects of travel? Now, there is no reduction. Dr. Mehta is back. Ravi, are you here?
Yeah, I am there, Murli. Sorry, I was re-logged in from the participant side, so I could not unmute myself.
No
So
problem.
it was like COVID, helplessly watching you asking me a question, but I couldn't say anything.
Yeah, so go ahead and then we'll come back to Dr. Gangakekar.
Yeah. So I think what you pointed out, just to complete your last point, that the lack of precautions is probably a reflection of what we would call in tech lingo, where Bangalore guys, a default mode. We've gone into default. Let's forget about it. In fact, it's a vengeance default. The masks are despised more than accepted. So rather than learning from lessons, it is like rejected in a very active way. So that's been the new thing, and that may be the return of the old norm, also called the new norm 2.0, maybe, to just put some fancy terms into that. Then to add to travel also is now increasing the whole thing. Clearly, if the virus, which we are seeing now, the variants, the multiple ones we discussed, are more transmissible, with a vengeance travel which has come, it has really become a widely spread phenomena. And let's not forget, international travel has opened like never before. So with all this going on, these are spreading. The incubation period of these is low, so they tend to also manifest very fast. They have more sequelae, though we talked of long COVID syndrome. Unfortunately, we've not talked a lot of long influenza syndrome. It is an entity by itself. It has so many issues, and most of our respiratory clinics and general medicine clinics must have been full of people who've come with this nagging cough and other symptoms which are unrelenting, and they come for relief. We try to look for in old disorders, like asthma and so on, but then we are finding, very interestingly, as a clinical observation, that some of them are just sequelae, but some of them are unmasking subtle, mild, or latent asthma, which was there in people. So I think very interesting how the shift has happened, how this reflects on public health, human behavior, how people are adapting to it. I think we have no option to the current behavior pattern. Things are open and here to stay. We're back to the old default mode. We have to just do what we can with the newer tools we have and look for more manifestations of the prior viruses, which are likely to create problems in the long run more than COVID-19, as was pointed out by all the eminent speakers.
In fact, Professor Biradar, that is a topic for a future webinar, long COVID and other long viral infections, because I think since we saw so much of COVID, long COVID came to mind. But I remember, practically every other virus leaves long footprints behind. Dr. Ravi Kirti presented a talk on post-viral arthritis, in our Bangalore API meeting. And that is something I wake up with every day. So like that, there are a lot of post-viral syndromes, which are, I think, only now starting to emerge, thanks to the recognition of long COVID. Yeah. So
Murali, can I add one more point on the therapeutic aspect?
Yes, please.
Yeah. So Murali, when it was mentioned about the oseltamivir therapy, it's very interesting that the original studies were done and mentioned the early administration of the drug in order to have an impact on milder endpoints. It's interesting how the critical care literature has insisted that we give the drug. That in patients with comorbidities, you may have a longer persistence of the driving virus with ongoing phenomena, which may be detrimental. So at any point when you discover in these patients with comorbidities, especially when they're hitting healthcare of a severe nature, go for it, give it. And since the availability has been easy over here and the side effects are minimal and the experience extensive, it has made its way into every part of our inpatient care, including ICUs and ventilator patients.
Absolutely. And that's, I think, the point that Dr. Gangakedkar also makes. At-risk patients, don't hesitate to use it. Those with mild disease, not at risk, perhaps we should wait and watch. I think I got that right, isn't it, Gangakedkar?
Absolutely.
Right, sir. And can you tell us a little bit about the travel and COVID infections and other infections? Because I think there's a lot more that's coming in, adeno being one of them.
Yeah, before I go to that, I would add one more aspect. Where should clinician focus to find out what would be impact of lesser known respiratory viruses? One must also look at not only outcomes that are coming out of that infection, but also its impact on underlying comorbidity. So does it increase the worst way? Is the control lost of whatever condition that they had? Should be another point that we have to keep at the back of mind. The second issue, you said talked about international travel. Now, I would bring one point to think that this is a global village. Flights, can take one person from one corner to another. It was just that in COVID, we started when we heard about Wuhan having 57 odd cases that were reported at that juncture. But we have to remember that China went for zero COVID strategy. Everybody went for zero COVID strategy. Even there was a lockdown. So it took almost 2 months for that infection to spread to so many countries. When we went for lockdown, there were about 80 odd countries, 81 countries, if I remember. 81 countries were showing infection. So largely, I may be confused. No, but what I'm trying to say is, this is a global village. Infection, any new infection that tends to come, especially respiratory infections, they are likely to travel the fastest. So there should be no room to think that perhaps any variant that you are somewhere will not be seen elsewhere. And that we have seen, especially with Omicron variant. It all depends on transmission efficiency as another parameter. If I have a very high transmission efficiency, perhaps the time that I will take to spread to other countries will be far shorter. So this is likely to happen. Now you talked about different vaccines being provided to different people. One of the issues that one must remember that the efficacy of these vaccines is going to be different. We know the efficacy is different. One of the ways in which we continue to harp upon giving boosters to nullify this impact is by the fact that we know that there is perhaps the Hoskins effect that you're observing even as of now. But then one must also remember that hospitalization and deaths are not being impacted adversely, even if you give a different vaccine, let's say bivalent vaccine. So which essentially means taking boosters is a key thing that we should do at this point in time. Those who have missed a booster precautionary dose should take one to protect oneself, because the virus has still not moved beyond Omicron. Now that can be challenged, saying that Omicron is not associated with severe illness per se. But we still, if you ask me, I tend to question myself, saying that whether the milder illness is a product of provision of vaccines and protection that tends to come due to it, or is it the virus alone that is changing, or is it a mixture of both? The virus is also changing, vaccine is providing some kind of protection, so you are seeing milder infection. But we cannot attribute to one or the other. So it would be good to take at least one booster, to my mind.
Absolutely. Dr. Singh, would you agree with that? Dr. Singh published a book. He was the editor of a book recently on COVID-19, a book which I thought was very well curated, very well written. Dr. Singh, what is your opinion on encouraging people to take the booster? What is the current coverage of, the precautionary dose? I won't call it booster, precautionary dose, because I think the government's wisdom decided to call it a precautionary dose. How would you encourage your patients to take more? Because there's now a loss of, worry about this virus. So very often people don't want to take the third dose. I have a lot of patients who've taken the first two and refused to take the precautionary dose.
I think, Dr. Murali, this is a very, very relevant question in today's scenario. I think I am clear about that we should also take this booster. Dr. Raman has already recommended. But as you told that although you are going to recommend to your patients, you should go for the vaccination or precautionary dose or whatever you say it. But that at this time, the present mindset of our public, they are not going to listen us. Even at least in 4 or 5 cases, when I sent to the vaccination center, there is lots of hurdles at present. They were not, they didn't entertain about this booster or precautionary dosage. So I think this is a very big challenge at present. Even about the mask, people are not hearing at all. Even if you go within the flights, I am traveling every week, but I have not seen even in any airlines they are. I have seen any person, maybe 1.1 or 0.2%. I am saying that they are masking. Otherwise, people are totally traveling without any fear. And sometimes I feel that this is not bad at present. As one slide, Dr. Ganga Khedkar also showed about that, about the present scenario. So I think it is a very, very big challenge. It is a social challenge at present. It is not a scientific challenge, but a social challenge. And I think it will persist. It will be very difficult to cope with it. So although we are going in the especially in special situations, then you can recommend it. But otherwise, in general public, my opinion is that you can recommend it, you can advise, but people are not going to hear it at all. This is the real ground scenario.
Thank you, sir.
Yeah.
So we have 2 minutes more, Dr. Biradar kindly extended the session to 8:15, though it was supposed to stop at 8. Ravi, I think we let you go. I think I've held you on longer than, I promised you. But would you like to give one sentence message before you leave?
Thank you, Murali, and thank you so much. It's been a lovely meeting. The message, I think, would be viruses are here to stay. We have to change our entire attitude right from detection, as was pointed out, data, clinical approach, looking at the various aspects of what our country represents and the infrastructure, as was pointed out. Look at therapeutic options, understand that treatment paradigms on the virus only go so far, understand the complication of the virus, including secondary bacterial infection and sepsis probably are the bigger killers, and using a combined knowledge and, as was pointed out, a global sense, we should be able to look at these ongoing epidemics, potential pandemics, and catastrophes with a much better lens.
Thank you, Ravi, and thank you for coming. We let you go now. For everybody on this group, Dr. Ravi Kamipalli has been sharing a lot of very interesting links to various articles. Please go through them. I think you can just copy paste them into your phone or into your laptop. We don't have time to go into all of those, but there is one question I wanted to ask, all our panelists, starting with Dr. Gilada. Dr. Gilada, I think one of the main things that happened with HIV/AIDS was that the world came together to find treatments, to find investigations, and it always starts with identifying the virus, identifying the cause of this strange condition. And we've learned a lot in the 30 years of that, since HIV/AIDS was first recognized. The speed at which vaccines were developed, diagnostic tools were developed for COVID-19 has never been seen before. But I think it sparked off, new challenges, but also new solutions. What do you think, looking back at your journey through HIV/AIDS for your patients and the COVID-19 pandemic? Do you see hope for, improved diagnosis in the future? And do you think if we had applied the same speed and diligence to diagnosis and management of AIDS, we would have come out with answers sooner?
Okay. What we can see in HIV is possibly there may be a cure in near future. We do not see any possibility of vaccine. There are several reasons, and that can be a topic by itself. What we can see is long-acting already there. We can take one after the viral load is settled at non-detectable, target not detected. Person can take the injection once every 2 months. But there are going to be broadly neutralizing antibodies. There are a lot of research is going on in Israel, in Japan, in several places. And whatever functional cures we have seen, they are not replicated in last 8-9 years, ever since we have seen the functional cures. So we are not even looking at functional cure being one of the strategy of cure. In the testing, we should try and reduce the window period. And that has been well done with the 4th generation test. But there can be more and more new generation sequencing, more and more use of PCRs, because now PCRs are cheaper. Even in blood bank, they should adhere to PCR. Or if they don't want to do PCR on every sample, those which are large volume blood bank, they should do a kind of a pool testing of PCR. 10 sample at one place. If it is negative, all 10 are negative. If it is positive, then we need to repeat 10. And currently, positivity rate is around only 0.5% or so. So in 20 pool, you need to repeat 1. So I think in that situation, we will minimize the transmission from those which are particularly like blood banking. Mother to child transmission pathetically is very poor in India in national program. 33% of the mother do not even report after testing. So I think that should be 0. Because that is without any kind of counseling coming in picture, any kind of behavioral change coming in picture, we can make it 0. Privately, we are able to do that. I don't know why a program has really failed in mother-to-child transmission. So by that way, HIV has done very well. The human psyche is all related to deaths. If there are no deaths, it doesn't make a news. It doesn't make any kind of behavioral change. So COVID also, when we see Delta, then a lot of people were using mask, etc. Now nobody is going to use mask. So mask mandate should be rather than mandate mask request. And you can say that if you're using mask, you are not going to punish. Only those kind of people will use mask. Otherwise, you cannot make any kind of mandates now. And it is a revolutionary ecology. Like we have come here to stay, virus has come here to stay. Virus has not come to finish the host. None of the virus, none of the bacteria, none of the fungal have finished the human race. So, and we have not seen any single new variant or variant after Omicron has come. So I think it is like to be just bubbles here and there. COVID is over. We can deal with the long COVID, etc., other issues, but COVID is all over. Thank you.
Thank you. Dr. Singh, closing remarks from you, and then we'll go to Dr. Gangakhedkar for his final summing up.
I think the closing remark, I just favor and I really praise Dr. Ishwar that he told that COVID is over, yes, it is over. Whatever you are getting, that will remain. So just enjoy your life. There is no need to panic. Every time something happens, the media creates a panic. And that is a big problem at present. Otherwise, things are normal at present and it will remain normal. Thank you.
Yeah, we never made such a fuss about influenza in the past, though seasonal influenza did cause a significant number of mortalities every year. Now, suddenly there's a lot of hype about things. And I think Dr. Gangakedkar's talk will help to, clarify things, not take away caution, but at the same time, emphasize the reason not to panic. There was so much more I wanted. Your talk was so fascinating. A lot of messages on the chat box have spoken about how informative your talk was, sir. So I'm going to ask Dr. Kamepalli, will you put your question if there is anything, because we're running out of time. I want to give Dr. Gangakedkar the closing remarks. Sir, any closing remarks you'd like to make? There was so much more. I was surprised when you spoke about the adeno COVID link, considering one is an RNA virus, the other is a DNA virus. How do these two interact? It just raises more questions the more we learn. But we don't have time for that. I'll just leave you with closing remarks and request Dr. Kamepalli to put his question on the chat box.
Sir, just I know we are late, so I would just put it in one line. We have seen how together the world handled COVID with new discoveries, whether vaccines or drugs. But for us, it is also important that to understand that the world has come together for a new infection, viral infection. But for us, we should never forget there are older infections which continue to bother us. We need to maintain the balance by working over both. Otherwise, if we follow only the fashion, we will still continue to have poor health indices. Over, sir.
Absolutely. And, to prevent new infections, prevent the impact of infections is the basic background health. And I think Dr. Ravi Kamepalli has spoken about how important it is to maintain the metabolic health of our patients, of our people. I wouldn't even call them patients. So that's the message he wanted to give. Please asking all folks to improve the metabolic health of patients. This includes, of course, other preventive measures such as vaccination. And very importantly, something that we can all do, take standard precautions. The Far East, Korea, Japan have followed this for decades, even before COVID. Masking in public, maintaining hand sanitation, maintaining unnecessary, avoiding unnecessary close contacts. All these are, I think, important precautions that we can take, we should continue to take, and emphasize to our patients to take, apart from all the standard matters of maintaining good health. I'll stop at this point. Thank our panelists. Thank Dr. Raman Gangakedkar for a brilliant talk. I learned so much from it, sir. Thank you. And thank Dr. Biradar for giving me this opportunity to moderate this session. It's always a pleasure to be here. Dr. Biradar, back to you, sir.
Thank you, sir. Everything has been discussed. Nothing has been left except to thank all the panelists, Dr. Gilada, Dr. Raman Gangakedkar, as usual, and Dr. Ravi Mehta and Dr. Murali Mohan for a wonderful moderation. I request Dr. Vishwanath to say vote of thanks, brief vote of thanks in line.
Yeah. Good evening, sir. Good evening, all. Indeed, it was a very fascinating talk. As Dr. Murali Mohan rightly pointed out, during COVID times, the assuring talk of Dr. Raman and Dr. Randeep, we were really looking forward to it, and now also it continues, probably even with the influenza or COVID pandemic. And brilliant, I can say so much information. Probably one of the CMEs where the moderator had to cut short and bring it down. Thank you, Dr. Raman sir, for that excellent talk. Dr. Gilada and Dr. Singh sir also, they gave a lot of good information. As usual, Dr. Vimeta was crisp and informative. I thank our chairman-elect, Dr. Murali Mohan, for moderating the session so well. Probably he was one of the face here in Karnataka. We used to talk to get assured whenever there was any issue with COVID. So I had an opportunity to discuss with him a lot. Thank you all. And again, special thanks to Dr. Biradar. He keeps, as sir said, getting the best minds to talk on excellent subjects. So overall, very nice and informative talk. Thank you, sir. Thank you once again.
Yeah. Lastly, thank all the attendees who have joined from all over the places. Thank you one and all, sir. Good night. Stay safe. Thank you one and all.
Thank you all. Good night.
Thank you. Good night, sir.
नहीं सर, हमको आइडिया नहीं है किसका सर.